you very much. And thanks, Jessica and the Hepatitis Alliance for organizing this, and for COLDA organizing committee for giving the community a platform on the very first day of COLDA, and for making sure that we have this session when everybody is still kind of like awake and engaged. I must say that stigma about hepatitis B does not have sufficient attention, nearly, and this largely is due to poor knowledge of hepatitis B across the board, from care providers, policymakers, members of the community, and the patients themselves. I'm sure that people in the audience would have more interesting stories to tell, so I wouldn't take up much of the time what we have for discussion. I am here today to speak on the perspectives of a provider in terms of stigma. And I thought I would do this by looking at three aspects. How does stigma directly impact clinical care for the patients themselves? How does it potentially impact our prevention strategies for the patient, for PMTCT, and for the broader population? And how does it affect our other efforts in terms of advocacy, trying to get our programs up and running? And I would use examples of patients that we have had in the clinic and challenges that we have had to support patients through to make the case. And I'm glad that Charles has spoken before me, because that has basically set the scene by highlighting all the different kind of like areas in which patients are usually stigmatized. In terms of clinical impact, I'll tell an example of a young man in the Gambia who was enlisted in the army. Government salaries are usually relatively low. If you're in the army, the pay scale is even much lower. So for most of them, opportunities like peacekeeping missions, which are funded either through the UN or other international organizations, is their break to make some decent earning that most of them would come back and buy a property or invest in their further development and things like that. But usually the shortlisting and the selection of troops for these peacekeepings comes with some medical examination, and many who test positive for hepatitis B are automatically disqualified, irrespective of your clinical status. This is something that we have tried to take up with the Army in the Gambia, with the Ministry of Health, and we have tried to push it up, further up, but it remains a challenge. So this young man is also in the military. He's hoping for a day that he would have the opportunity to be selected for this training. And because of that, he had to drop out of care from our clinic because he cannot be taking permission from his commanders every 3 months to come back to clinic for a medication refill, or every 6 months for him to repeat his labs and his FibroScan. And this is clearly an impediment to his own care and well-being. Due to his financial situation, he has to prioritize his earnings and his job to protect it, but at the detriment of potentially not having the adequate care he needs, not having access to the treatments that could be life-saving for him. And right now, we just hope that nothing negative becomes of him in terms of healthcare. Another example, similarly with the Army, I'm sorry, retired Major, but I'm using the Army as a distinct, but some patients for whom we were able to negotiate for them to be left to go on some of these peacekeeping missions, we made arrangements to be sending them their medications all the way to Darfur so that they don't have to transfer out of care, because it was made clear to us that if the commanders at the peacekeeping side know of their status, they will be sent back. This is a problem, and we've had other systemic problems like people in the UAE and other Arab nations being deported back, either if they're on scholarship or work visas, because they test positive for hepatitis B. But long story short, for this individual, they ran out of medications. We were trying to organize medication to send to them, and we had no way of sending it because all of their deliveries are centralized at the base and then sent out to them wherever they are and their placement. And their things are searched, and if they see the medication, then questions would be asked. So these are really problems that go well beyond the patient, affects the patient care, affects how they navigate, like their day-to-day lives and their well-being, and all of these have an effect. And then in terms of treatment adherence, I can only imagine that if you have an infection that you need to take medication regularly, but you're unable to share your status, it makes it difficult to keep the drugs at home, to be taking them every day without anybody finding out. And this can, I can imagine, only have effects on your medication adherence. And then to the next point, in terms of potential public health impact, again, real-life examples of what we've seen in the Gambia. Last year, the Gambia received support from the Global Fund for Hepatitis Prevention Services. So currently, the Ministry of Health has access to surface antigen testing and antiviral prophylaxis for those who are hepatitis B positive who meet the eligibility criteria. But more than often, we've had women who test positive for hepatitis B, but would refuse reflex testing for DNA, would not want to take prophylaxis because they cannot explain to their husbands or to their families why they're taking this treatment or how they got infected. And we can only imagine that this would have an impact on the prevention of mother-to-child transmission and for their subsequent linkage to care after delivery. Again, all of these would have direct clinical impact for the patients, but also larger impact for the prevention. And of course, if we are currently talking about using antenatal screening, which is likely going to be the entry route for the largest screening for hepatitis B in the continent, using that as an index to find close contacts, like to broaden hepatitis B's diagnosis. But women are having that challenge of disclosing their status because they cannot be guaranteed of getting the support they need from their homes. Then that strategy will not work, and it just makes the whole issue of finding the millions that are not diagnosed on the continent even harder. And finally, and this is my last point, there is only so much that we can do as care providers to shift the bar and convince our governments and ministries of health to invest in hepatitis services. I think the best we can do is generate the evidence and present it to them. But nothing carries as much weight as the patients themselves mobilizing and going to the policymakers and demanding that they need the care. We have seen examples of this where in the Gambia, again, our PMTCT services, when women test positive and we tell them that they need to demand for the birth dose immediately after they give birth, we have seen a drastic increase in the birth dose coverage because they would demand it from their midwives. They will make sure that like whoever has the vaccine would come and administer the vaccine to their babies. So we can only imagine that if they can also mobilize and go to the policymakers, somehow they would be able to find ways to increase access to treatment and diagnostics. But if patients are stigmatized to the point that they're scared to disclose their status, then again, this will not happen. So I think we all have major responsibilities, not just see the issue of stigma as a concern for the patients, and that it's World Hepatitis Alliance and their partners who needs to mobilize and do something about this. It's having direct impact on our patients' well-being, our prevention services, and the strategies that we are hoping to implement for viral hepatitis elimination. Thank you very much.